Welcome. In this session and the next we are going to discuss about the orbital inflammatory disorders, and in this session we have the major one, thyroid ophthalmopathy, variously known as thyroid eye disease, Graves' ophthalmopathy or thyroid orbitopathy, and it is the most common cause of both unilateral and bilateral proptosis in adults. Now, one general point to note about orbital inflammation is that when a patient presents with orbital inflammatory symptoms and signs, we have to first exclude infection. After excluding an infection, we have to look for known conditions causing orbital inflammation, and for that we have to perform lab tests and biopsies. Among the lab tests, we have thyroid function tests and thyroid autoantibodies, as well as several other tests which are directed towards the known causes of orbital inflammation. Apart from thyroid ophthalmopathy, a biopsy is required in most cases of orbital inflammation to make a specific diagnosis. And when we have ruled out an infection as well as a specific orbital inflammation, by lab tests and biopsy, we make a diagnosis of non-specific orbital inflammation, previously known as orbital pseudotumor, which is a diagnosis of exclusion. Thyroid eye disease or TED is also known as thyroid-related ophthalmopathy or TRO. Thyroid orbitopathy or Graves' ophthalmopathy is an inflammatory disorder of the orbit associated with autoimmune thyroid dysfunction. The orbital involvement is characterized by hypertrophy followed by fibrosis of both the orbital fat and the striated muscles in the orbit, that is the extraocular muscles as well as the levator palpebrae superioris muscle. And TED was originally described as part of Graves' disease, which was a constellation of hyperthyroidism orbitopathy associated with pretibial myxedema. TED has a bimodal age of onset, with one being in the 5th decade and the other being in the 7th decade for both males and females. But on average, males have slightly later onset than females in each of these two groups. And TED is 6 times more common in females. Smoking is a known risk factor for TED, and it increases the risk up to 7-fold as well as the severity of TED. TED in males in older age and in smokers predicts more severe disease. The hyperthyroidism is caused by aberrant lymphocytes producing antibodies which can stimulate receptors for thyroid stimulating hormone, and these antibodies are also called thyrotropin receptor antibodies or TRAB or TSH receptor antibodies. Pluripotential fibrocytes in the orbit are the main target cells of the autoimmune process in the orbit, and these fibrocytes are present in both the orbital fat as well as in the skeletal muscles of the orbit, and these fibrocytes have receptors which are stimulated by TRAB. Unlike other fibroblasts or fibrocytes, orbital fibrocytes possess CD40 receptor which can be stimulated by T cells, and they have surface receptors for IGF, that is insulin-like growth factor 1, which binds to IGF-1 and potentiates adjacent receptors for TRAB. The orbital fibrocytes, upon stimulation by TRAB and IGF-1, produce pro-inflammatory cytokines such as IL-6, IL-8 and PGE2, secrete hyaluronic acid which increases the volume of the orbital contents, and they transform into adipocytes, resulting in fat accumulation in the orbit. Diagnosis of TED is based on any two of the following three: current or recently detected thyroid abnormalities, ocular and orbital signs, and radiologic abnormalities. 94% of patients with TED have thyroid abnormalities. The remaining 6% of patients are euthyroid endocrinologically but have serologic evidence of autoimmunity against the thyroid gland. Among the 94% of TED patients who have thyroid abnormalities, the majority, that is 90%, have Graves' hyperthyroidism. And out of the remaining, 3% have Hashimoto's thyroiditis, which is actually a form of hypothyroidism, and 1% have primary hyperthyroidism. It is important to remember that only 30% of patients with Graves' hyperthyroidism have TED. So we do not have orbitopathy in most of the patients with Graves' hyperthyroidism. When a GH patient develops TED, there is a close temporal correlation of onset of GH and TED. 20% of TED have simultaneous onset with GH, 60% of TED occur within 1 year of onset of GH, and in the remaining 20% of TED patients, TED precedes GH, with GH occurring within 5 years in 50% of patients. As we have mentioned, 3% of TED patients have Hashimoto's thyroiditis, which is actually a form of hypothyroidism, and 1% of TED patients have primary hyperthyroidism. 6% of TED patients are euthyroid endocrinologically, but they have circulating thyroid autoantibodies, and these are called TSH receptor antibodies. These TSH receptor antibodies are classified as TSHR stimulating immunoglobulins TSI or TSHR binding inhibitory immunoglobulins or TBII, and the TSI antibodies more closely correlate with activity of TED. Role of antimicrosomal antibodies, also known as thyroid peroxidase antibodies and thyroglobulin antibodies in thyroid eye disease, are not well defined. Serum T4, T3 and TSH are helpful in the diagnosis of TED, being one of the criteria of diagnosis of TED, but they are not useful in monitoring the clinical activity or the treatment response of the orbitopathy, because clinical course of ophthalmopathy or orbitopathy may not parallel the clinical course of thyroid dysfunction and its treatment. But when serum T3, T4 and TSH are normal, thyroid immunoglobulin levels, that is TSI or TBII, help in diagnosis of TED, but they are not routinely used for diagnosis but may help in monitoring the disease course. The second criteria of diagnosis of TED are the orbital and ocular symptoms and signs. The symptoms include dull and deep orbital ache, double vision, decline of vision, photophobia and lacrimation. And the signs of TED can be either unilateral or bilateral. So lid retraction is a very typical sign of thyroid ophthalmopathy, which leads us to the diagnosis of TED in most situations, and lid retraction is associated with a lateral flare. That is, the retraction is more in the lateral aspect of the eye than in the medial aspect of the eye. And lid retraction is the most common presenting feature of TED, and TED is the most common cause of lid retraction. So here we have a patient with bilateral lid retraction, and in this photograph the patient has unilateral lid retraction. Upper lid retraction is most commonly due to enlargement followed by scarring of levator palpebris superioris muscle, but lower lid retraction is mainly due to the proptosis itself. The upper eyelid retraction of TED is characteristically associated with an upper eyelid lag, also known as the von Graefe sign, in which on downward excursion of the eyeball, the upper lid lags behind the movement of the eye with increasing superior scleral show. Normally, when the eye moves from the primary position to the downward position, the upper eyelid follows the superior limbus, and the distance between the superior limbus and the upper eyelid margin is maintained. But when there is a lid lag, the upper eyelid margin fails to keep pace with the downward movement of the eyeball, and so the sclera above the superior limbus becomes visible. In this diagram, lid retraction has not been shown. And as we have mentioned, lower lid retraction is usually due to proptosis. TED is the most common cause of both unilateral and bilateral proptosis, as we have mentioned, and this is very important to remember. TED is a cause of restrictive myopathy, and most commonly the inferior rectus muscle is involved when we find hypotropia and or deficient elevation of the eyeball on upgaze. So here we find left hypotropia in primary position and deficient elevation of the left eyeball on upgaze. Less frequently, medial and superior recti can be involved, and lateral rectus is involved only infrequently, and this sequence, medial, superior and lateral recti, are in decreasing order of frequency of involvement in thyroid eye disease. TED can cause compressive optic neuropathy due to expansion of the orbital contents, particularly the extraocular muscles in the posterior orbit, and compressive optic neuropathy results in visual acuity decline, color vision abnormalities, relative afferent pupillary defect if asymmetric, and visual field defects. And it is found that inferior paracentral visual field defects are the most common in thyroid eye disease. Inflammatory signs of TED which indicate the current level of activity of the disease, include conjunctival hyperemia and edema, as well as eyelid edema and or hyperemia. And the eyelid edema or hyperemia can have diurnal fluctuation. So the orbital and ocular signs of TED are lid retraction and lid lag, proptosis, extraocular muscle dysfunction, optic nerve compression, and inflammatory signs such as edema and hyperemia of the conjunctiva and the eyelid. Two-thirds of TED patients have primarily fat involvement, often with focal LPS inflammation, and they present with proptosis and eyelid retraction. And this usually occurs in young, predominantly female patients, and they have a slowly progressive course. The remaining one-third of TED patients have predominantly muscle involvement, and these patients more frequently present with edema and hyperemia of the conjunctiva and eyelid, and can have restricted ocular motility as well as compressive optic neuropathy. And the muscle predominant form of TED occurs in older patients without sex predilection. Muscle predominant TED have a rapidly progressive course and is associated with smoking and a positive family history. The third criteria for diagnosis of TED are the radiologic signs. On CT scan, we find fusiform enlargement of any of the recti or LPS muscles, usually in the order inferior rectus, medial rectus, superior rectus, and lateral rectus. And characteristically, there is pairing of the tendons from enlargement in TED. And this is very important to remember because it differentiates TED from other orbital inflammatory processes. There will also be enlargement of the orbital fat spaces and crowding at orbital apex. In this picture, we find enlargement of the inferior rectus muscle and the belly of the medial rectus muscle, but sparing of the tendon of the medial rectus muscle from enlargement. The inferior rectus muscle appears like this in an axial CT scan near the floor of the orbit. And on CECT, during the active phase of the disease, we find contrast enhancement of the sheaths of the extraocular muscles and increased fat attenuation. That is, fat appears brighter than it normally is, and this is also called fat stranding. During inactive phase of the disease, there is reduced contrast enhancement of the muscles as well as loosened spaces within the muscles. On magnetic resonance imaging during the active phase, we find edema of the muscles on T2 or stud sequences. And a B-scan ultrasound of the orbit can show enlargement and moderate to high internal reflectivity of involved muscles. TED can be associated with pretibial myxedema and acropathy. And acropathy and pretibial myxedema are poor prognostic indicators for TED. TED can also be associated with superior limbic keratitis and autoimmune diseases such as myasthenia gravis, diabetes mellitus, alopecia, and vitiligo. Now, if a patient has thyroid eye disease along with myasthenia gravis, there can be ptosis instead of lid retraction. TED is a self-limited disease and on average lasts 1 year in predominantly fat-involving disease and 2 to 3 years in predominantly muscle-involving disease and in smokers. And the course of TED follows the Rundle's curve, which depicts that there is initial worsening of the disease activity with worsening of symptoms and signs, followed by partial resolution of symptoms and signs, but the disease does not reach the baseline, so some symptoms and signs remain even after treatment and resolution of the disease. And in only 5 to 10% of TED patients, there is reactivation of the disease over their lifetime. Clinical grading of thyroid involvement is important from treatment point of view, and there are 3 well-known systems of clinical grading. The first one is the NOSPECS or Werner's classification, and the NOSPECS system describes the severity of the disease but does not grade activity or give treatment recommendations, which are found in the other 2 systems. So NOSPECS consists of no signs and symptoms, only signs of lid retraction without any symptoms, soft tissue involvement, proptosis, extraocular muscle involvement, corneal involvement, and sight loss. And they are graded as 0, A, B, and C according to their severity. The VISA clinical grading system has been developed by the International Thyroid Eye Disease Society and allows for both activity and severity grading. and the letters in the name derive from the initials of the components of the disease according to decreasing order of urgency in the management of the aspects of the disease. Vision, strabismus and appearance grade severity of the disease, and eye or inflammatory signs grades activity of the disease. And the activity scoring or VISA eye score is done both at initial visit and follow-up visits, and conjunctival chemosis, eyelid swelling and retrobulbar egg gets 2 points each, whereas swelling of caruncle, conjunctival erythema, eyelid erythema and diurnal variation of the symptoms get 1 point each. A score of 3 or less is managed conservatively, but if the score is 4 or more or there is signs of progression, aggressive management is instituted. And treatment of thyroid eye disease can be conservative, aggressive or elective, as we will come to soon. Clinical activity scoring system or the CAS system allows only activity grading, which is required for deciding on immunosuppressive therapy, and on presentation or baseline 7 criteria are scored like the VISA system, except that here pain on eye movement is included but diurnal variation is not. But unlike the VISA system, each of these 7 criteria get 1 point each. In the CAS system, at follow-up between 1 and 3 months, all the baseline criteria are again scored, but in addition 3 more criteria defining progression of the disease are also included, and they are more than 2 mm increase in proptosis, more than 1 line decrease in nail and visual acuity, and more than 8 degrees of change of impaired duction in any direction. And each of these criteria also get 1 point if present. And if the score is 4/7 or more in the initial examination or 5/10 or more in the follow-up examination, the ophthalmopathy is defined as active and aggressive treatment needs to be instituted. So in summary, no specs defines severity of the disease, CAS defines activity of the disease, VISA describes both the severity and the activity of the disease. Treatment of thyroid eye disease can be described separately as conservative, aggressive and elective. Most TED patients can be managed conservatively, and this includes cessation of smoking, restricting salt in the diet and sleeping with head end of the bed elevated to reduce orbital edema, and topical lubricants, sunglasses and topical cyclosporin for ocular surface issues. And some patients may require temporary prism glasses during active disease for diplopia, Botox for lid retraction and extraocular muscle restriction, and selenium supplementation is recommended in selenium deficient areas. Hyperthyroidism must also be treated, and euthyroid status is one of the goals of treatment of thyroid eye disease. And this can be achieved with antithyroid drugs, and in recalcitrant cases radioactive iodine can be used. But radioactive iodine may cause worsening of the orbitopathy, and worsening of orbitopathy can be controlled with steroids and also with thyroxine supplementation to reduce the TSH secretion from the pituitary gland, which occurs due to the hypothyroidism ensuing from treatment of hyperthyroidism. For recalcitrant disease, thyroidectomy may need to be done. Aggressive management is required for patients with high inflammation scores, corneal compromise and optic nerve dysfunction. Presence of corneal compromise and optic nerve dysfunction requires urgent treatment. We may note here that extraocular muscle dysfunction and lid retraction without corneal exposure does not require aggressive management but can be treated electively. Orbital inflammation of thyroid eye disease is primarily treated with steroids and/or biologics. But some patients of orbital inflammation may need orbital radiation therapy or orbital decompression surgery, and we must not confuse between orbital radiation therapy for orbitopathy and radioactive iodine therapy for hyperthyroidism per se. And one recommended regimen for steroid therapy is weekly pulse therapy 500 mg to 1 gram intravenous methylprednisolone for 6 to 12 weeks, with the maximum cumulative dose not to be exceeded being 6 to 8 grams. And this has been shown to reduce complications of oral steroids, but weekly IVMP needs close monitoring for hepatic dysfunction. An alternative regimen is daily oral steroids in a tapering dose over 6 to 12 weeks. Biologics which have been used for TED are teprotumumab, which is an anti-IGF-1 receptor antibody, and this may cause hyperglycemia and hearing loss as side effect. Tocilizumab, an anti-IL-6 receptor antibody, may cause gastrointestinal ulcers and respiratory infections. Rituximab, an anti-CD20 antibody, has also been used for treatment of thyroid eye disease. As mentioned, orbital radiotherapy and orbital decompression surgery may help in recalcitrant inflammation. Orbital radiotherapy results in a slower onset but longer lasting reduction of inflammation as compared to steroids, and it should be combined with steroids for controlling immediate post-radiation flare-up of inflammation. Orbital decompression surgery may help in recalcitrant inflammation by improving the venous drainage, thus reducing swelling from inflammation. Optic nerve compression from TED is a medical emergency, and it is primarily treated with orbital decompression. And for predominantly fat hypertrophy disease, also called type 1 orbitopathy, fat decompression is done. And for predominantly muscle hypertrophy disease, also called type 2 orbitopathy, bone decompression is done. For bone decompression, either outfracture of the medial orbital wall into the posterior ethmoid sinus and or outfracture of the medial portion of the orbital floor into the maxillary sinus inferiorly are done, and fat decompression and bone decompression can be combined as required. So here we find a patient who has undergone bilateral orbital decompression, and we can see enlargement of the orbital spaces as compared to the preoperative picture. Orbital radiotherapy is also a treatment option for compressive optic neuropathy, or can be done following orbital decompression surgery to prevent further deterioration. And as we have seen, orbital radiotherapy provides slow onset of but longer lasting reduction in inflammation. And also initially there can be worsening of the inflammation, which can be controlled with steroids. Usually a total of 20 gray or 2000 rads are fractionated over 10 days through a lateral port, avoiding ocular and intracranial exposure. However, orbital radiotherapy may worsen diabetic retinopathy and may cause secondary malignancies. Pulse steroid therapy may provide partial resolution for compressive optic neuropathy and can buy time for orbital decompression surgery and orbital radiotherapy. Corneal exposure is another medical emergency of thyroid eye disease, and tarsorrhaphy should be done immediately to provide protection to the exposed cornea. And IVMP radiotherapy and orbital decompression surgery reduces corneal exposure by reducing proptosis and provides more long-term solution. Elective surgery for thyroid eye disease may be required for correction of proptosis, muscle dysfunctions, lid and skin issues, but elective surgery for these problems of thyroid eye disease should be done only after achievement of the euthyroid state and control of the inflammatory signs for at least 6 to 9 months. And there is a specific sequence in which the necessary surgical procedures should be done. First, the orbital decompression as required should be done, followed by strabismus correction as required, followed by correction of lid retraction as necessary, and at the very last, aesthetic skin surgery if required should be done. And this is because orbital surgery affects the position of the eyes, strabismus surgery affects the position of the lids, and lid surgery affects the appearance of the skin. Proptosis requires orbital decompression, and this can be either wall decompression or fat decompression. An orbital wall decompression is usually done in the floor or the medial wall of the orbit, and only occasionally the lateral wall is operated on. Decompression of the floor of the orbit can result in inferior globe displacement, cheek numbness from injury to the infraorbital nerve, increase of upper eyelid retraction, but may cause decrease of the lower lid retraction. Medial wall decompression can cause sinusitis or involvement of the anterior ethmoidal nerves, causing numbness of the nose. Lateral wall decompression can result in oscillopsia during mastication, as lateral rectus comes in contact with the temporalis muscle. As we have mentioned, strabismus can occur following wall decompression, and this occurs particularly in patients with muscle dominant disease who actually need wall decompression. This picture shows the pre-operative and post-operative photographs of a patient who has undergone orbital decompression For thyroid eye disease, restrictive strabismus requires recession of the involved muscles, which may be one or more recti muscles and usually with adjustable sutures. And recession of inferior rectus muscle, the most commonly involved muscle in TED, can actually worsen lower eyelid retraction of thyroid eye disease. Lid retraction can be corrected by recession of the LPS and molar muscle for the upper lid and recession of the lower eyelid retractors for the lower eyelid. In this patient, lower eyelid retraction in both the eyes has been corrected by recession of the lower lid retractors in both the eyes. With appropriate treatment for thyroid eye disease, long-term morbidity can be prevented, but psychological impact of cosmetic and aesthetic defects can be significant. Thank you for listening.